And before I start my talk, I would like to give a story, a very short story of one of my mentors called Maximilian Kolbe, who was born in 1894. He gave himself to the church as a priest, but in the year 1941, he was arrested by the Nazis just because he assisted some refugees from the Jewish community. Later, 10 of the prisoners in the concentration camp where he was put escaped from the prison, and to punish the rest, 10 of the prisoners were chosen, another 10 burned to be killed by being put to be starved for 1 week to die. And then Maximilian Kolbe, one of the men there cried that he has a family, he's going to die, he's going to leave his family with no one to support. So Maximilian Kolbe gave his life and said, let him die on behalf of the other man. And he was put with the rest to starvation for 1 week. Some men died, others didn't die. Himself, he didn't die, but then they were injected with carbonic acid and they were incriminated. He died. Why do I give you that? Because this is a time for us as anesthetists where we give our lives for our brothers and sisters. We know that we risk ourselves by going in for a patient who is COVID positive, but still we go in because we know that we are there not for ourselves, but for other people. And I want to quote one of the wise men, Ben Carson, who said that happiness does not result from what we get, but from what we give. And then from there, I want now to open my presentation with a short case scenario of a man who was aged 34 years and had no allergies, and he presented to us. It's now 12 days since he presented to us that time. He had a complaint of hypothermia of 40 degrees and severe abdominal pain. That's when he came to our hospital, and the patient had been with us again for an appendectomy, and then he recurred on the 5th day with the above complaints. The RRT team suspected he could be COVID positive, so they isolated him while we awaited for the lab people to take the samples and give the result. Meanwhile, while in the ward, he was put on PCM, tozobactam, and azithromycin. On the 2nd day, the patient had improved. He had no fevers. The diagnosis was meant for peritonitis, and clinically, the RRT people declared that he was not COVID positive, though the results were not yet out. And a plan for an X-lab emergency was done, as we all know that peritonitis is an emergency in surgery. By then, the temperatures were at 36 degrees, and physical findings, he had distended abdomen, which was tender. He didn't have DIB, and all other parameters were all within the normal ranges, though we had some derangements. In the HB was 8, the WBCs were elevated, was 17, the potassium was normal, sodium was normal, and chlorine and urea was elevated at 10. But then we went in because we had been told that he's not positive for COVID-19. And in the theater, everything went essentially in the standard way. The induction procedure was a bit difficult. We had 3 attempts before we could succeed to have the airway secured, and the surgery ended within an hour, uneventful. Unfortunately, on the 3rd day, while the patient was in the surgical ward, the results came out that he was COVID positive. It is a challenge to definitely identify a COVID-19 patient without appropriate testing. But remember that as frontliners in care of patients, the prime purpose in life is to help others. That is said by one of the wise men called Elson Kefa. It is imperative, therefore, in any suspected cases to take all the necessary precautions and guidelines unless proven negative. I would like to take you people through the normal evaluation of a patient who is COVID positive, and then we'll go to the anesthesia management, but I'll focus more on specifically for COVID patient. I won't go in a general way. So in the history taking, we look for the presence of a dry cough and fever, shortness of breath, traveling history to high-risk areas, close contact with a positive patient, a cluster pneumonia which is visible in a chest X-ray. In the physical examination, we'll check for the presence of fever, check for blood pressure, the pulse, look for presence of shock, SpO2 for desaturation, auscultation for crepitations and wheezing. Look for leukopenia, lymphocytosis from the CBC. We need to assess for organ functions, given that these patients could have, if they were already confirmed positive and perhaps started on antiretroviral drugs, they could have effect on their liver and in the renal function. So it's necessary to look at that. In addition to that, while we are checking on that, we need also to check on if the patient has been on other drugs also, because also the drug interaction, especially the ARVs, where we have drugs like Kelectra, which is potentiates midazolam and fentanyl, chloroquine, which also changes the pH of the patient. And if we do the ABGs, we may find derangements in that. In the CT thorax, if available, you need to look for presence of multilobular ground glass appearance. I think yesterday, for those of us who followed Dr. Matthew from Vanderbilt, he had these screenshots and they are very clear on the X-ray as well as the CT thorax. Sorry. In the operating room, now after you've done our checkup, before I forget, after you've done all our checkup, if it's a patient who is not COVID confirmed to be positive, also to be vigilant because the disease is still new with us, and some patients will not appear with the classical clinical features as the ones I've just gone through. Because I want to give an example that the first patient in our hospital tested positive for COVID never had any of the symptoms until the third day. He came to the hospital with epigastric pain, and it was a DM patient whose the glucose levels were elevated. Was put in the ward, and on the third day, the patient developed DIB and was isolated. Lab works were done, and later the results came that he was positive. So let's not focus on what is said, what is documented, because every patient is different and every experience is there to teach us. In the operating room, we need to prepare, as we mentioned last week, that this patient needs to have an isolation theater, which have negative pressures, whereby we'll use the IC and we'll ensure that the air from outside is not coming in, from in is not going out, to prevent pollution to the environment. Ensure timely notification of all the team in theater, the anesthesia, the nurse, the surgeon, that the patient coming next, if in case we have just isolated one of our main theaters for that, the staff should know who is coming in, and we should ensure that we have the proper PPs required in the theater, and we should have designated equipment, including disposable ones for the confirmed cases. Necessary to put up a sign in the door so that someone doesn't come in accidentally. They cannot that someone outside cannot that the procedure for the patient who is COVID positive is still on, and need to take precautions. You need to utilize, as I've mentioned, the airborne infection isolation room for recovery of extubated patients to minimize unnecessary contact with the staff and other patients. Identify or establish protocols for decontamination of the room after the suspected or the confirmed case. Before induction, We should ensure all the staffs are on their proper PPEs. We should do the gowning, put on the hazmat suit, all those stuff. And when we come in, the staffs who are to scrub, for this particular patient, there is no normal scrubbing as usual. They'll do the sanitizing way, and a glove and a gown with their sterile attires. It's necessary to take all the risks because the patient could be contagious to anyone in the room, and all precautions required are necessary. Check all your equipment to ensure they are working before you induce your patient. And as our last week's presenter said, that we should prepare everything, not to start intubating, realize it's a difficult intubation, the bougie is in another room, you need to change maybe the blade, already you risk yourself, you risk the people assisting you. You need to insert a bacterial or viral filter in the expiry limb. And if possible, put both insert bacterial viral filter as well as our normal HMEs to ensure that no possibility of making our machine to be unsafe for another patient. During induction, it's necessary to minimize the number of people in the room. The people who are not necessary to assist the anesthetist during the intubation should be outside. This includes the scrub nurse, the surgeon, unless they are the people to assist you in the procedure. But if you have another anesthetist with you, you have assistant with you who are well prepared, then you can have those people and have all the rest out of the room until you have secured the airway. And as we all know that the most experienced person should be the one to intubate this person. It's necessary to double glove, and we see in the next slide where we must double glove. We need to pre-oxygenate the patient with the minimal gas flow possible, less than 6 liters. So why? Because too much airway pressures, too much air will make us not to have a good seal. There'll be leak outside the face mask, and all this endangers us all. Give fentanyl slowly in small doses if required to reduce the possibility of coughing during induction. And for this patient, we should utilize the rapid sequence induction to reduce the risk of mask ventilation. We need to maintain the airway patency and ensure the onset of paralysis before performing intubation to avoid coughing. Use two-hand grip to optimize seal if mask ventilation becomes really necessary. If it's not necessary, we should avoid it. But if it's necessary, please let's remember we should put a good seal. Should release the pressure valve so that at any time we don't have high pressures of our gases. Minimize tube and circuit disconnection. If it's really necessary to disconnect, there are two ways. One, we should put a clamp on our ETT so that we don't have chances of air coming from the patient outside the environment, or rather you place a ventilator on the standby whenever a circuit disconnection is required, such as tube repositioning. Should always remember that we should use a closed suctioning system to avoid contamination. And we must always restart our mechanical ventilation or any positive pressure ventilation only after the circuit has been reconnected. Employ lung protecting mechanical ventilation strategies by maintaining a low tidal volume of 5 to 6 mL per kg. Increase respiratory rate to maintain minute ventilation, keeping the peak airway pressure below 30. Another thing I should mention at this point before I come out is that after you put in our tube, we're not going to use the normal procedures we know. After putting the tube, you bag, listen, ventilate, and listen to the chest. No, you're going to put in the tube and then curve the tube and then directly connect it to our machine. Don't put any positive pressure until the curve is the curve has been curved. That's our first statement here says, that any positive pressure ventilation should be after the ETT curve is inflated. At this point, you need to remove your outer gloves after intubation if using a double glove technique to reduce the environmental contamination. Then after, while you having now one glove, you use the pre-cut tapes to secure the ETT. Just as we had mentioned that you need to prepare early, including cutting of our tape. Confirm the tube position by observing the bilateral chest rise, not by auscultation at this time. Because auscultation may be difficult due to personal protective equipment which you have already put, and we don't want to expose ourselves. So at this time is the time we are allowed to intubate, and we don't auscultate. You can use an ultrasound if it's available to check for your tube, but if you use all the other maneuvers, as we know as anesthetists, you can check the chest expansion, you can check for the forming, you can use a capnograph. There are many ways to confirm that your tube is in position. Then after that, you can now perform hand hygiene. Anesthesia maintenance will go as per the patient and as per the choice of the anesthetist. At this time, when the surgery is over, we need to prepare for our emergence. So we need to give our antiemetics to minimize the chances of vomiting. We should ensure smooth emergence and minimize coughing in these patients. You need, as I mentioned earlier, to use a closed sanctioning system for the ETT. And then after, when you have extubated your patient, normally we take our patients to the PACU for the recovery part. At this time, we are not taking them there. We are going to recover them in the isolation room, in the isolation theater. Why? Because in the process of taking them out, we are likely going to cause more risk to the people, the other patients in the PACU, the other people in the environment all around us. So this patient, we should only reverse and take them through the process of recovery in our OR. Arrange for case handover with the receiving team in the operating theater, that the people from the isolation ward should come to the operating theater and get their patients directly from there. When you are taking the patient out at this time, we should remember to use a route as we used, possibly as we should use while coming to theater. It should use a route which is not a busy one, not where we are meeting everyone on the corridor. And the same should happen while we are taking them out. We should not just take them in a route which everyone else is passing and getting in contact with the patient. Then strictly adhere to the proper degowning at designated location and perform hand hygiene. Clean and disinfect high-touch surfaces of the anesthesia machine and anesthesia work area with appropriate hospital disinfectant. Then you should allow time for the aerosol in the isolation room to be washed out, at least 1 hour before we can take in the next case. In cleaning of the area, there are some chemicals which have shown to work better, that when they get in contact with the virus, in 1 minute, it's dead. For example, we have povidone iodine, which we use in operating theaters to clean the patients. We use it 10%. But at this time, for the virus, for the COVID-19 virus, it's adequate to use 0.23 to 7.5% to disinfect, and we are sure we don't have a virus around us. Hydrogen peroxide also at a concentration of 0.5% has shown to work well. Ethanol at 0.1%. All those take 1 minute and the virus is washed out. Take home points for us is that COVID is with us, it's here to stay, and we should learn how to work with it. Precautions are required for aerosol generating procedures. Modification of the airway management are required to minimize aerosol generation, as I've mentioned earlier. And then regional anesthesia should be considered where possible. Disease transmission can be minimized when perioperative care is thoroughly planned. In this, it's necessary for the team in theater to do some drills to prepare ourselves for when it is an emergency, so that when it comes as an emergency, then we don't get mixed up with where we should touch, where to start and all that. But when we wait for the day we get COVID-19 patient in an emergency setup, then we shall find ourselves having contaminated ourselves for not having well prepared ourselves. We must protect ourselves, others, and the patient. So I've finished. Those are my references. I have a last slide here. This slide is showing this person intubating. If you can look at it well, is apart from the PPEs the person is putting on, is having an intubating box. There are some countries where they have invented their way of protecting themselves by having even an intubating box with them. So thank you, everyone, for listening, and it's time for questions.
So thank you, sister. I think there were a few people who had their hands raised. I'll ask everybody to send in their questions through the question and answer section, because that will be easier for us to coordinate. But I'll ask the first question, which was sent in by Eric. He asks, kindly elaborate more on the closed section and what one can do if this is not available.
Thank you, Eric, for that question. Closed system, they are used mostly, you find them in the ICU setup, where the suction, the tube is fixed in a way that you put in it, you suction, you remove it, it goes back to its cover automatically. And if it's not available, then as our last week's presenter did, we can just use the normal suction. You suction the patient and you put in a cover of that yanker back again, so that it can protect the environment before you place it on the side of the bed or on the machine. Thank you.
So our next question comes from Mubarak, who is from Somaliland. Mubarak, welcome. So Mubarak asks, if you don't have PPE or a face shield, do you double mask? What are your thoughts on it? I don't know if is Jude still with us? No, he got lost. So sister, what do you think about that?
Thank you very much, Mubarak. I think double masking can help, but will not help completely. Because remember, if you have to put a face shield will cover more than the mask would cover, because the mask is only covering the mouth and the nose, but the face shield is covering the whole of our face. So it still stands a risk. Maybe if you don't have all that and one is able to do a homemade intubating box, then could help better, because the aerosol generating procedures are always there with us and won't avoid the contamination of ourselves, of our faces. Like if the patient in any chance accidentally happens to cough, then the mask will not protect your eyes, will not protect your ears, will not protect your cheeks. Thank you.
Yes, and I'll also add that there are ways that you can make your own face mask. So I have seen people using what is it called? This paper that you use for binding covers. The plastic cover when you're binding this ring. I don't know how to explain it, but there are ways you can make face shields. So what maybe we can do is, if we find links for how to do that, we can send to you, because it's always important to know how you can improvise when you don't have the proper equipment. But there are ways to have a homemade face shield. So we'll share that with you. So Samuel asked, which I also asked you, did you go for quarantine after this procedure?
Well, I was waiting for that question. Thank you, Samuel, for that, and for Gatieri for the same question. ideally, that's the best thing to do, that you could have gone for quarantine in good setups where there is plenty of everything, plenty of resources, including human resource. I work in a rural hospital, and the resources are limited, of course, as you know, in Kenya. And when we did the contact tracing, we were like 40 staffs who had got in one way or another in contact with this person. You can imagine quarantine or isolating 40 staff, then you collapse the whole surgical department and theater. Otherwise, what we did and what we are doing in our hospital when we get such contact, because they are coming every day, that patient changes condition while has been in the ward for 5 days and all that. What we are using is N95 for all of us, and know that we are risk to the people because we have not yet been diagnosed and all that, and we don't know if we have gotten the infection. So we've done our best. We've not gone for quarantine, either isolation. We've used N95 all the time within the hospital premises, and we've tried to limit necessary contacts with people, we wash hands and such a stuff. And we've already finished, yesterday we finished our day 10. None of us has any symptom, and we are comfortable. Thank you.
Thank you for that answer. I know that's something that we struggle with. Every time a health worker has to go to quarantine or isolation, that has a big impact on the team, because we're already few as it is. So understand that. So there are others who are sending questions in the chat, so I'll move between that and the question and answer section. So we've been asked, how do we manage a patient with difficult intubation when you suspect COVID?
Well, for example, our patient, when we had this patient and I tried laryngoscopy twice, it wasn't going. Lucky the buji was near me and we were able to go through. Well, glide scope and all other advanced technologies are always the best for such patients when we suspect we are going to have a difficulty airway. But in our side, we only went with buji. So you just prepare whatever is available at your facility in case of that. If you have to bag the patient in between, if you get difficulty, remember to have someone who helps you to hold firm the seal of the mask, and while you are bagging, or you hold it firm and someone bags for you, so that you minimize the chances of the aerosol.
Yeah, and I think one thing that has been emphasized during this COVID time is always make sure that the most experienced person is the one doing the intubation. So it's important to have that experience, so that even when you're intubating someone who might have a difficult airway, that experience comes into play. But as Sister said, make sure that you have all your equipment ready, and if you need help, have help available with you, and always make sure PPE, protect yourself. Make sure you have the mask, the face shield, you've double gloved before you attempt any intubation. So there's somebody who asked, I didn't hear about the outcome of the surgery. Well, did the patient survive?
Of course, the patient survived. It said that the surgery took 1 hour, was uneventful. When we went in, we found there were hematomas. There was an active bleeder which was left possibly after the first surgery, but it had already sealed and there was a lot of clots. So we just cleaned up and closed again. So the patient later was taken to the isolation, the county isolation, which is in the Meru Hospital. But he's doing well. But that was day 3, so already had been removed and the wound site was okay. So he went there to be managed now for the COVID part of it. That's
good to hear. So Moses asks, when patient is on sub and he or she starts to desaturate, the initial tendency is to remove the mask, and sometimes I feel afraid, but then desaturation is worrying. What is your take on that?
Well, Moses, you need to look at what is the cause of the desaturation. Is it that it's a high spinal, or what has happened with the patient? And of course, if you remove the mask, the surgical mask the patient is having, definitely you should put immediately the mask from, you connect your circuit and give oxygen to the patient with a low flow so that we have less leak. It's good to avoid use of nasal cannulas because they have more leak. That's what I could say. I don't know if Kateri, you have something more.
No, I think as you say, use your clinical judgment to manage the desaturation, but always know that in a surgical situation there's a reason why the patient is desaturating. So as you treat the symptom, always try and find out what is the cause. As sister said, it could be a high spinal, so it's important to be thinking through. That's what anesthetists do. You have to be very quick on your feet and thinking about what could be causing this desaturation and manage it appropriately. But as we said, make sure that you're already protected yourself. In this COVID time, treat everybody like they have COVID, even if it's not confirmed. Suspect everybody. So protect yourself. Do the proper PPE as is the protocol says, and I think that's the way to go. So the next question comes from Kateya. He said, if you don't have an intubation box, what can you modify?
Katia, thanks for that. I don't have an intubation box. It's something I've come across in the literature, what some advanced and developed word anesthesiologists have gone for. And I think it's good for us also to look around and see how we can even improvise one from whatever is available with us and have it homemade, and we can be good to go with it. I just wanted to add a bit on the patient who is desaturating. It's always good for us to check if the monitors are well placed, because sometimes the patient, we see them desaturate, but the monitor is not in position, so we are like managing the machine, not the patient. So let's check on that. Check if the patient is cold, because if it's cold, then that patient doesn't need oxygen, need to be kept warm, and then we see the oxygen circulation go up. Thank you.
If I could add.
Please go ahead. Yes.
On the same issue of intubating a patient, if you don't have the intubating box, the key thing is you need to have a face shield on top of the N95 mask, so that you're able to protect all your other areas, your eyes and everything, so that you don't get into contact with any secretions. I think also to add on a question that probably went answered earlier when I was off network. When you have donned fully, you have your full PPEs, the N95 mask, you have a face shield, and your head is fully covered, you're considered low risk. Okay, so most of the time I've had to go see patients in the isolation ward 3-4 times, and I've not had to go to quarantine. And I've taken 4 COVID tests now, and all of them are negative. So if you're able to protect yourself fully by donning fully, and then taking all precautions while doffing, I think your risk is low and you'll be able to get on well. Thank you.
Thank you for that. So we will move to the next question, which is from Josephat. How long should you wait before you use the OR in case you don't have an isolated OR for COVID patients? So I think you had answered that in the presentation, but you can just reinforce that message.
Yeah, thank you, Josephat. Sorry.
Okay, go ahead, sister.
Yeah, the literature which I've been able to come across was that you can wait for 1 hour after all the disinfection has been done in that OR, just to ensure that everything is well set again and the team is set again for the next surgery.
Yeah. Jude, do you have anything to add? Has it gone again? It's fine. So George asks, do you recover the patients in the room, or do you transfer directly to the OR, or do you establish a separate PACU? That's his first question. His second question, negative pressure rooms, does it mean no air in and no air out? And if so, in this case, do we in this case concentrate aerosols in the room, thus make it more risky for the team in the OR? So just
Thank you.
explaining.
Let me start with the last question. The other one it has gone off my mind, but you remind me again.
Yeah, I'll remind you.
In the negative pressure room, it means that everything is contained in the room. We can only use the IC to suck out the gases, but not through the doors and unnecessary holes here. And again, as I said in my presentation, that we are using a closed system, whereby we don't have the excavation pot in our machine. We use that one whereby every gas from the patient is recycled again through the solder line and goes back again to the patient without any escaping outside, unless the one which will accidentally escape during our ventilation and all that. So that is the meaning of closed a negative pressure room, and the only way is one, IC. Secondly, using a closed system. Sorry, what was the other question?
If I may add.
Recovery. For the recovery of the patients, do you do it in the OR? Do you do it in a separate PACU? Or where is it done?
Yes, it's done in the recovery to avoid contaminating more rooms and more people, because if we take to PACU means we have to have a nurse for PACU again recover. If we do it in the room, then the only person exposed is the anesthetist and the person assisting in the anesthesia from the very beginning. Because we also want to reduce the contact, because more contact the patient gets, more risk for many people to get the disease and all that. So we recover in the room. The OR.
So Eric asks you to kindly take us through the extubation process.
Thank you for that. In the extubation process of this patient, let me go to the mentions. Okay. Okay, in the extubation process of this patient, we need to ensure that the patient doesn't cough during our extubation. So in this, I would suggest we go the deep extubation, whereby the patient is able to take adequate tidal volume, the patient is able to recognize pain and all that, but we don't wait until the patient is fully awake, because the more we wait to be fully awake, the more the chance of the patient coughing. Then we can remove our tube and maintain the airway clear without really necessarily having to wait until the patient is fully recovered to meet all the criteria for extubation. I don't know if I've answered Eric about it.
May I add?
Yeah, Judy, thank you.
Yes. You can also connect the suction tube to the ETT, so that as you pull it out, all aerosol material that are in the chest or whatever is coming out of the patient is sucked into the machine, and therefore we're not able to contaminate the environment. So it's essential that as you extubate the patient, you connect the suction tube on the ETT, so that as you pull out, everything is sucked into the machine. Thank you.
Thank you.
Thank you for that question. I think the next one will be something that everybody should share. Samuel asks, he says, thanks sister for your good work and presentation. Do you have a weekly CME for COVID-19 with among theatre users? And I think this is a question that all of us can respond to through the chat box. Tell us what your experience is within your facility. Do you guys have CMEs for theatre users in your facility? So you can give us the name of your facility and say either yes, we have CMEs, or no, we don't. So Sister Agnes, do they do that at Kirwa?
Thank you, Samuel, for that. Yeah, in Kirwa, time to time we have CME in theater. We always talk about COVID is the topic of the current thing, and we've had several CMEs about it, and today, in fact, today I was talking with the theater in charge that we need a drill, because in our hospital we've decided we've chosen one room a bit out of theater, which is used as the minor theater, to make it to be safe for COVID patient or suspected COVID patient who will come in an emergency and we need the surgery done. So we've set it, and we want to finish settling it. And on Monday, we have a plan to have a drill for the theater staffs, for all of us, so that when then an emergency comes, we know what to do, where to touch.
So the next one is also more of a comment. This is Rose. She says, we have some KN95 masks labeled for non-medical use. So majority of us prefer to use 2 surgical masks and a face shield, and we hope we are safe. So I know that PPE is a challenge in very many places. So the thing about this is to be very vigilant. Take all the necessary precautions, because if we lose one of you, we've lost a generation. So just be careful. I don't know if any of our panelists have anything to add on.
Yeah, thank you everyone for attending this. Thank you for your questions, and Gatueri for organizing it. And I want to just finish with one statement from one of the wise men called Brian Tracy, who said
we have more questions.
Oh, sorry.
Hatujamaliza. We've not finished. So I think we have about 5 more questions, and then maybe we can finish. You can give us your last word. So yeah, Dennis asks, after how long was the anesthesia machine used after that patient?
Well, Dennis, this one is a dilemma, because our patient, when he came in, was already tried and cleared by the RRT for COVID negative, because he didn't have any more signs of it, and everyone thought that it was all about peritonitis. So when we came in, we didn't expect that we are dealing with a COVID patient until 3 days in the ward, when the results came out from the last sent that they were positive. So our machine, we didn't give it time. We did our normal cleaning and changed all the things. We usually change the circuit and all that, and went on as usual.
So the next question comes from William Little, sorry. What are your comments if the patient codes and needs ACLS management?
Thank you, William. Last week, our presenter told us that if the patient codes, we should not resuscitate if I had him well, because in the process of CPR, then we increase the risk of contaminating everyone in that procedure of CPR.
And I think like that question came up, and we had promised to send you, there's a modified protocol for ACLS in our COVID suspected case. I think one thing they emphasize on is full PPE. If everyone has full PPE, then I think it's okay to attempt, but clinical judgment in all these things, clinical judgments is very vital. So we shall share that resource with you guys, and yeah, and Jude, you can.
Yeah, if the patient codes, like Gaturia said, it's basically a judgment call. If you are fully donned, then you can attempt CPR. And it's advisable to do CPR in the prone position. That is one of the modifications that has been done in the current ACLS protocols, especially for COVID suspected patients. It's advisable that first and foremost, the patient needs to be intubated with a cuffed tube. Then you flip them over and you do CPR with the patient in prone position so that you minimize the chances of spreading the infection to the environment. But the key thing is all people participating in the CPR need to be fully donned with the fully PPEs, the face shield, and N95 masks. Thank you.
Thank you. So somebody asks about I think they meant face shield. This is Olubai, asks whether it's single use or can be disinfected.
A good number of them can be disinfected, taken through the sterilization process, but depending on which type you have, I would advise that you use them once and discard, because most of the ones we see in the market are not things you can reuse. So if you have a good one that can be re-sterilized, then that would be fine to reuse it. But for the ones like the one that guy is putting on that photo, just use it once and discard.
Thank you. Eunice asks, in a COVID positive patient with difficult intubation, do you still extubate deep, or which one is best?
Well, just like we said, it is a judgment call. But you want your patient out in an environment where they're able to protect the airway and they feel you feel they are safe. So if this is a candidate for deep extubation, then go ahead and extubate them deep. If this is a candidate who should be extubated fully awake, bearing in mind that this is a difficult intubation, extubate them fully awake, taking the precautions that we mentioned earlier. Make sure you have your suction tube ready, connected to the ETT, and suction as you come out, so that you're not going to contaminate yourself and the environment. So it is okay to extubate them fully awake. It's okay to extubate them deep, depending on what kind of patient you have. Unmute yourself, Gatwiri.
Sorry. So somebody asks what the saturation pre-op was for this patient. That's Patrick.
The patient was stable, and as I said earlier, wasn't said to be COVID. So when we extubated the patient, we recovered the. Sorry, my internet is getting unstable. We extubated the patient and recovered in the PACU. Lucky enough, it was at night, so we didn't have another patient in the PACU. But the circulation was all within normal, and the patient went to the ward talking and everything stable for him.
So thank you. I think this will be okay. I think we have 2 more questions and then we can finish. Rabar asks about, apart from the standard IPC considerations, what are the special considerations for the anesthesia machine and airway equipment? So this is one question that was answered in last week's webinar. I don't know if we want to refresh their memory a little bit.
Well, the standard precautions remain. The ETT needs to be single use. Once you're done with it, you discard it. The machine, the breathing circuits basically need to go through the whole process of disinfection and re-sterilization, depending on what the hospital policy is on that. And basically, for sterilization of the machine, you need to call in the biomed or the dealers to be able to come and sterilize the machine. Otherwise, none of us actually knows how the machine needs to be sterilized. But then there is a minimal chance that we actually infected the machine. So the machine would actually be safe for the next patient, for as long as we remove all the other parts that were in contact with the patient, that is the breathing circuit and all that. But the rest of the machine, once the HME was used and viral filters, then we're actually safe to use the machine. But it would be nice to contact the biomed and the dealers to be able to advise you further on how the machine can be sterilized. Thank you.
So I'll ask the last two questions. So I'll combine two questions, one from the chat and one from the question and answer. So do you have an anesthetic disposables, e.g. laryngoscopes, breathing circuit, etc. available for use? And then somebody else says, please comment on LMAs. So I'll ask the ones who are raising their hands, please, either type in the chat or in the Q&A box. It would be very difficult for us to maneuver and let everyone speak. So please use those two functions. Yeah. So Jude, what are your comments about anesthetic disposables? I've never seen.
Well, I've not seen a disposable circuit. We had some disposable laryngoscope blades that we used last time when we had a surgical camp. And I think that is the only time I've seen disposable laryngoscope blades. But otherwise, the ones we use are basically reusable. So we just need to take the infection prevention measures, take them, the blades through decontamination and the sterilization process, and be able to make them safe for the next patient to use. As for breathing circuits, I haven't seen any disposables, although most manufacturers would say single use, but we are in Kenya, and we know that if we decide that we want to use all those circuits once, then in a month we will not have anything to use. So basically, we end up re-sterilizing them and using them again. So the key thing is you will need to go through the whole process of decontamination and re-sterilization of all equipment that are used. Thank you. And for the LMS, that is tricky because a good number of them would not be able to give you a tight seal, and some air would be able to leak out while you're doing a positive pressure ventilation. So that would be tricky to use in a COVID patient. You will be contaminating a lot of the environment. I wouldn't advise use of LMS in COVID patients unless it is for rescue purposes in an environment where you attempted intubation, it is difficult, and you didn't anticipate it, and now you're trying to bring out the patient. That would be the only time I would advise for use of an LMA, but for basically maintenance of anesthesia, not a good idea. Thank you.
We have 3 minutes remaining. I'll ask our panelists to give their final comments. For anyone who feels that their question has not been answered, I've put our email address on the chat box, so you can send us any additional questions on email. So I'll also put my number. You can send your questions on WhatsApp, and I'll forward it to the relevant panelists for them to respond. So thank you so much for coming. I'll give Agnes a chance to give us her final comments.
Thank you so much, Gacheri, for the opportunity. I want to encourage my fellow anesthetists. Let's remain on the front line. Let's not fear. Let's not retreat from the battle, and let's always keep safe. This is it's a hard period for us, but patients still need our help. I want to finish the words of Brian Tracy, who said that successful people are always looking for opportunities to help others. Let's be successful people. Let's look for the opportunities to help others. While unsuccessful people are always asking, what's in it for me? And in this period of COVID, if we become unsuccessful, we shall ask, what is in it for me if I go in to assist that patient and we retreat? Thank you. God bless you.
Jude, any last words?
Well, thank you for organizing this. I think this was an important session for us. Thank you, Sister Agnes, for the nice presentation. It was well done. And for the team out there, let's keep safe and just remember that there is a supreme being somewhere who watches over you. For as long as you have good intentions as you go to take care of a patient and try to save a life, trust me, God is going to make sure that you come out safe. He will take care of you in a way that you never imagined. Otherwise, take precautions, keep safe. We need all of you when all of this, when this thing is done. Huh? Thank you so much.
Our chairman, Bwana Samson, any final comments?
Thank you, Gacheri. Can you hear me, guys?
You're not very clear, but
thank you very much. I thank you guys, especially Sister Agnes, my neighbor in this local and I'm sorry for you with some of those COVID patients. I think I will be managing some of them coming out from you. And you are doing what you are doing there. It's without you, I don't know how far you can go.
Mr. Chairman, Mr. Chairman, your sound is not very clear, but I think
yes, I realize we have some issue. So can you hear me now? I think, yeah, thank you. So what I just want to summarize is that this is a very informative information. Colleagues, I can just tell you, COVID, we have already lost one analyst. We have lost two nurses, and we also know we have lost a doctor. We have to protect others, protect patients, and also protect our machine. As you know, we have several of these states. I will ask our colleagues not to miss these sessions. They are very important. Today, at least we were system 4, and I hope in the future we shall be more. And next week, as usual, we shall encourage more colleagues to attend. Otherwise, I will encourage each of you to be safe. Let's continue giving safe anesthesia. And God, as Sister has said, it is important we sacrifice for the nation, for the country, for our families, and we are ready to go. Thank you very much, and you have a good evening. Thank you.
so. Thank you, Mr. Chair, for the comments. Somebody has WhatsApped me already and asked me, in this picture, the patient here has a mask on. So usually when you're intubating the patient, you'll take the mask off. But if a patient doesn't need intubation, have them have a mask on during the case. So for all the Kenyan nurses, this is a CPD accredited session. Unfortunately, we've not gotten our secret code from the Nursing Council yet, but we shall, once they send it to us, probably on Monday, we shall make sure that we email it to you, and that's one of the reasons we asked for your email addresses. We'll send them to you, and if possible, if you want it faster, send me your name and email address on WhatsApp so that I can also share it with you on WhatsApp after I verify that you attended through your email address. Then we shall be having these sessions every Friday from between 7 and 8 p.m. So you're all very welcome to join us next week. We shall be emailing you information on when the next session will start, along with the sign-in codes for the same. So if there's any question we've not answered here, we shall provide this information either on email or on our website. So feel free to send in more questions. We are happy to answer them all. So I thank Sister Agnes very much for making time to speak to us tonight. I think everyone enjoyed the talk that you've given us, and it's good information. So this information is only good if it's practiced and shared. So please make sure that you apply everything that Sister has taught us tonight and share it with the communities that you work with. So those theater users, if there's no CME being done in your facility, you've attended one, so you can organize one for them and teach them what you've learned tonight. So thank you very much and have a good night. We shall see you next Friday. Thank you.
Thank you too.
Bye-bye.